does it mean equal access? And she says that it's the ability to secure a specified range of services, so you need access to the whole range of services for everyone, and a specified level of quality, so you need to provide the whole range of services at the same level of quality, independent on who the patient is. And there shouldn't be a difference in the personal inconvenience and the cost people have to bear to access that type of care, while in possession of a specified level of information. If you make it more concrete, it means that if you send letters, for example, to the higher educated people, for them it's, and you send it to the lower educated people and they can't read, then the higher educated people have more information. For them it's much more easier to access the system than the lower educated people. So you may say, I send everyone the same letter, so I'm equal, everyone gets the same letter. They don't have to pay for the care. We have it in Belgium for the mammography, for example. Everyone gets the same letter. They don't have to pay for it. But what you see is that the lower educated women don't show up. And when you talk about the people organizing it, they say there is no inequity. We send the same letter to everyone and it's free and it doesn't cost. There is an inequity because you don't give them all the same information. So when you talk about access, it's not only do they show up on my doorstep, but how much trouble they had to do to show up on your doorstep, and didn't your system have barriers in that access? Yeah, what I wrote down here, and I'm not going to go into detail in this, is that if you look at determinants of access, what do we talk about concrete? If you want to evaluate your system and whether it's accessible or equitable in access, how do you measure it? And I put down some of the possible indicators that you can use to measure whether your system is equitable in access. And one of the things you can look at is, for example, the availability of your system. Is your volume distribution different in different areas? In Belgium, you see that, for example, there are regions in Belgium, mostly the deprived areas, where we have less GPs per 1,000 inhabitants than in the more in the less deprived areas. So that's your availability of your system. Also, how is your system organized? The availability, is your doctor available through the phone or not? Your appointment system is something that can make your system more or less accessible. And appointments is not always a very accessible way for people in low socioeconomic classes. Waiting times are important, distance to practices, delays because of financial reasons. Can you go to your doctor if you don't have health insurance? Or do you have to have that before you can go? But also the characteristics of your healthcare providers. If you have only male GPs in the region, then your system is not equitable for men and women, equitable concerning access for men and women. For women, it will be more difficult to access a doctor then because they feel a barrier when it's all men. So the characteristics of your personnel is also an indicator for access to care.
What about the fact that if you haven't got doctors, as the doctors does not want to work in that area?
Yeah.
We've got that trouble. We do have trouble with getting doctors to the deprived areas. So you need to have that. It's very important. And the doctors coming there have much more patients than in other areas. As the colleague, the neighbor has left half a year ago and he couldn't be replaced. So that's very important.
We are starting to have that problem in Belgium now.
And it is a huge problem.
Huge problem. And we try to make a payment system where you pay extra for doctors working to stimulate it. Well, money is not everything, so like yesterday, but sometimes it could be a motivation to be able to have a smaller practice in these things. But well, not to interfere with your presentation, but I think it's a part of it.
We have the money in, but it doesn't help.
It doesn't help.
Yeah. system, but also equal treatment for equal need. Yeah. And it seems normal, it seems obvious that we do that, but we don't, because there's really evidence showing us that higher income groups really receive higher income, higher quality care, also in Belgium. Yeah. And then equal outcomes for equal needs. People in equal needs, people with the same problems, with the same need for care, need the same outcome to be able to speak about an equitable healthcare system. And what we see is that even in systems with the same access and with same treatments for all patients, what we see is that sometimes the outcomes are different and outcomes are less good. And that also has to do, for example, with circumstances for recovery. If your patient has an important surgery and comes home and his recovery plan is going much more difficult, the final outcome will be different. And you don't have an equitable healthcare system when there's differences in outcome. You have to make sure that the patient with more problems gets more care and more recovery care. So what we wanted to tell you is, or one of the main messages that we want to give is that equity is, we think, a very important aspect when you look at quality of care, and it is mentioned in the list of the model of, the efficiency and cost effectiveness. And equity is a part of it. But equity is more about, it's more than only about access to care. So that's an important message. And the question is how the concept of equity can be taken into a model for quality improvement. And how can you improve equity on practice level? And if you measure your quality on practice level, how can you measure equity? Whether your practice is equitable or not equitable. And that's a wonderful discussion.
Yes, about equity and vaccination against flu, influenza vaccination. It was a good practice in Antwerp. It was very successful in vaccination for risk patients. They had 85% vaccination rate. They were very happy till one of the doctors said, okay, let's have a look to two groups. The groups who live here in Belgium, and the groups are from abroad, from Moroccan and Turkish background. And they were looking to the vaccination rate. And there was a huge difference. It was 60% for the American population, and still high, 80–85% for the indigenous population, the Flemish population. So they discovered only with an analysis, looking to perhaps there are differences, that there wasn't a real difference. Then they looked how it is, and they had some qualitative interviews, some structural interviews with patients they called, and the letter they received was handled in another way. So people who are used to receive letters to plan, they have a special place in house, and the letter is there, or on a flip over or something else. So, oh yes, I have to go for my vaccination. That was not a tradition in American households. So they did it in another way, and they did it in a more cultural way, that some key persons of the groups were informed about flu vaccination. And with the oral tradition, they informed other ones to come for specific consultations targeted to the American community. And that worked better than the equal distribution of letters. So they had totally another approach, no letters, but the oral tradition using to have high performance. And this only began, the start was let's look in another way to our registration. Let's make some difference in subgroups.
Do you have any examples of inequality or special efforts to get equity in your practice, or do you have suggestions for measuring equity? Because I think we are really at the start of this. And when we looked, for instance, into the IPA tool, if there was any indicator about equity, we have only found six, and the most important one was if the practice was accessible for wheelchairs.
It's a big question, but I can see in my department for research in general practice, we have made a literature study to see what kinds of efforts can we do to catch the people and catch the vulnerable people, and also according to, I think it was a good way to not only talk about equity and access, but also treatment and outcome. And the overall experiences, it's very spread, but it says that's the local and personal contact that have the effect. That means that, and some of us have said it here, it's the personal contact with patients that makes the difference, that you take care of the patient. They can be ethnic minority, alcohol, or whatever, but it's the personal relationship that works when we talk about equity. This raises for me some problems because we know how to do it, but it also takes time for the practice to make this. And I think this is a bigger challenge. I think we can do it, but how do we get the room for doing it? And how can we measure this kind of initiatives? We can, because it's not only I have sent out so many letters twice. It's also I've contacted her cousin because of our don't speak Danish, and so how do you document these activities? I cannot get you the answer now, but
yeah. But we should start thinking about it.
Yeah.
I do believe so. That's one thing I keep from what you say. The other one is how important GPs can be in not only measuring and mapping inequity, but also in finding solutions for it. And that I also heard, because we have this personal relationship with our patients, and now perhaps the different needs easier and better than to someone from the government or from the country or things like that.
I think it is